Hey everyone, and welcome. If you are getting ready for your exams, or you just want to get way sharper with your clinical skills, you are in exactly the right spot. Today, we're taking a really deep dive into peripheral vascular disease, or PVD. We're going to break this whole topic down, piece by piece, so you can absolutely master it. Let's jump in. So here's our game plan. We're going to start with the real fundamentals, the core problem. Then we'll look at how these diseases actually show up in a patient. After that, how do we diagnose and treat them? And what are your priorities as a nurse? And we'll wrap it all up with a rapid-fire NCLEX review and a little clinical scenario to put all that knowledge to the test. All right, let's kick it off with Section 1, the core problem. Getting this foundation right is so key because literally everything else, all the symptoms, all the treatments, it all flows from understanding the basic mechanics of what's gone wrong in the first place. So first things first, what in the world is PVD? Well, think of it as a big umbrella term. It basically covers any disorder of your blood vessels that's happening outside of your heart and brain, out in the periphery. And 9 times out of 10, we're talking about circulation problems in the legs. This right here, this is the key that unlocks the entire topic. The single most important question you need to ask yourself is this: is the blood having trouble getting into the tissues? Or is it having trouble getting out? That one simple question changes everything. And here are our 2 main players based on that very question. If blood has trouble getting in, that's an arterial issue. We call it Peripheral Arterial Disease, or PAD. Think of it like clogged pipes from plaque. But if blood has trouble getting out, that's a venous problem. That's chronic venous insufficiency, or CVI, where the little valves in the veins fail and blood just pools. It really is all about inflow versus outflow. Now, a lot of the risk factors are the usual suspects you'd expect for any kind of vascular disease, and they're shared between both conditions. But I really want you to look at that first one with the star next to it, smoking. It is a massive, massive contributor and a huge priority when we're talking to our patients. But then we have some specific risks that should make your clinical brain start leaning one way or the other. For PAD, if you see a history of atherosclerosis or coronary artery disease, that's a huge clue. For CVI, you want to be thinking about things that just increase pressure in the legs, like a previous blood clot or a job that has someone standing all day. Okay, moving on to Section 2, manifestations. Now that we've got the core problem down, let's talk about what these patients actually look like when they walk in the door. This is where you really learn to tell these two apart, both for your exams and, of course, at the bedside. So for PAD, our arterial problem, the absolute hallmark sign is something called intermittent claudication. This is textbook. The patient says, my calves cramp up when I walk to the mailbox, but as soon as I stop and rest, the pain goes away. And why? Well, when they walk, their muscles demand more oxygen, but those narrowed arteries just can't deliver enough blood. You'll also see those physical signs of bad circulation: cool skin, pale, shiny, no hair growth, and really weak pulses. Now, stop. This is absolute exam gold. The 6 Ps. We're not talking about chronic PAD anymore. This is an acute blockage. This is a limb-threatening medical emergency. If you see a patient with these signs, especially the later ones, like numbness, tingling, or paralysis, you have to act immediately. Okay, now let's flip to CVI, the venous problem. See how different this is? The pain here isn't with walking. It's an aching or heaviness that gets worse with standing because gravity is making that blood pooling even worse. You're going to see swelling or edema and that classic brownish color on their lower legs. And here's a huge clue. Their pulses will be just fine because the arteries are working. So you see a patient, you're piecing together the clues, and you're thinking it's one of these conditions. How do we prove it? And what are we going to do about it? That brings us to Section 3, diagnosis and management. When it comes to diagnosing PAD, there's one magic number you have to burn into your brain, and that number is less than 0.9. This comes from a super simple test called the Ankle-Brachial Index, or ABI. And here's how easy it is. We literally just compare the blood pressure in their ankle to the blood pressure in their arm. They should be about the same, right? Which gives you a ratio of about 1.0. But if that ankle pressure starts to drop and the ratio falls below 0.9, bam, that's a diagnosis of PAD. The lower the number, the worse the disease. Managing PAD takes a few different approaches. Lifestyle changes are the absolute foundation. Quitting smoking isn't just a suggestion, it's non-negotiable. And a walking program is huge. Then we'll add in meds like aspirin and statins. And for really bad blockages, we can go in and physically open up the artery with a stent or even a bypass graft. Now for CVI, the strategy is totally different because the problem is different. It's all about helping that blood fight gravity and get back out of the legs. And the number one absolute cornerstone of therapy is compression stockings. That, plus elevating the legs, exercise, and weight management, is the name of the game. All right, let's get to one of the most important parts for your exams and for your actual career. Section 4, Essential Nursing Priorities. This is all about what you, the nurse, are going to be doing for these patients. Okay, for a PAD patient, what's our goal? We need to get blood down to the feet. So what do? We use gravity. We keep their legs in a dependent or downward position. And look at those huge safety warnings. You would never, ever put compression socks on a PAD patient. That would just squeeze the artery more. And no heating pads because they can't feel heat properly and you could cause a terrible burn. And now for CVI, we do the complete opposite. Here, we want blood to get out, so we elevate the legs up above the heart. And here, compression isn't just okay, it's the main treatment. So the big takeaway is PAD, legs go down. CVI, legs go up. Whew, we have covered a ton, so now it's time to boil it all down and lock it in. Welcome to Section 5, NCLEX Gold. Think of this as your rapid-fire review of the most critical must-know points. This slide, right here, this is your ultimate cheat sheet. Seriously, if you can understand this table, you can answer pretty much any question that tries to make you differentiate between PAD and CVI. Just look at those beautiful opposites all the way down. Inflow versus outflow, walking versus standing pain, pale versus brown skin, dependent versus elevated. This is what it all comes down to. And here are the pearls, the quick hit facts that you'll see on exams all the time. If they mention claudication that gets better with rest, it's PAD. If they give you an ABI of less than 0.9, it's PAD. And just remember the positioning. Arteries down, veins up. And compression is for veins, period. Okay, need a way to make this stick? Here's a memory hook that goes straight to the core of the problem. Just think. Arteries can't get blood in. Veins can't get blood out. If it's an IN problem, it's arterial. If it's an out problem, it's venous. Simple as that. And here's the second hook. And this one is super practical for your nursing care. For PAD, down is better. For CVI, up is better. It's so simple, so effective, and so easy to remember when you're standing at the bedside trying to figure out what to do. All right, for our last section, let's put on our clinical thinking caps. It's time to go from just knowing the facts to actually applying them in a situation you might really see. This is where clinical judgment comes into play. So let's break this down. We've got a 68-year-old guy, smoker, diabetic. He gets cramping pain when he walks, and it goes away when he rests. His feet are cool, shiny, and have no hair. What are all these cues just screaming at you? This is a textbook classic presentation of peripheral arterial disease. So knowing what you now know, what's your next move? You recognized all the signs, pointing to an arterial problem. What's the number one priority assessment you need to do right now to confirm what you're thinking and figure out how bad it is? Think about the tools we talked about, the signs we reviewed. What's going to give you the most critical piece of information? We'll leave you with that to think about. Thanks so much for joining me today.